Go for it.
Okay. Good morning. Our presentation is on use of prophylactic anticoagulants to prevent thromboembolism. Our group members are Haley Bianco, Kaylee Calhoun, Gregory Eiler, Jennifer Martinez, and Vanya Soto, which is me. And I will begin with the introduction. So venous thromboembolism, also known as a VTE, is a blood clot that can present anywhere on the body. Typically, you see it in the lower extremities, like the calf area. When it presents, you will feel swelling, redness, and tenderness upon dorsal or plantar flexion. This can lead to a complication called pulmonary embolism, which could lead to respiratory issues, ultimately leading in death if there's no interventions provided. Healthcare-associated VTE can occur anytime during hospitalization and discharge, and it is most common within 3 months after hospitalization if adequate measures are not taking place. Risk factors can include a large majority of people. Any hospitalization due to illness or surgery is included. People who experience physical trauma, like a car accident, are at high risk of VTE. People who experience cancer, pregnancy, they also experience these events. Obesity gives an older age of 55 plus, gives you a higher risk as well. Immobility associated with hospitalization and long bed rest gives high incidence of VTE. And smoking or chronic diseases like cardiovascular and diabetes will increase the risk as well. So as we can see, it includes a wide range of people, and no particular person is not at risk of this happening. So the CDC has designated VTE a public health issue that is in need of being addressed. Up to 900,000 Americans experience VTE, resulting in up to 100,000 deaths on a yearly basis. Up to half of those, 550,000, are associated with hospitalization. These 500,000 people, the CDC estimates that up to 70% of these cases are preventable when appropriate known interventions are taking place. And because the incidence is so common, up to $10 billion are spent yearly in the associated costs to care for these patients. So as a result, the CDC has provided a campaign called Stop the Clot to increase awareness and improve patient education, because we see that this is where a lot of information is lacking. Patients just don't know that this is an issue that can occur to them during hospitalization. And current treatment options would be including mechanical prophylaxis, which includes early ambulation after surgery, passive and active range of motion exercises that enable the participant to do as much of the exercise as possible. SCDs, which are stockings that you put on the calf area to facilitate circulation, or compression stockings. Pharmacological prophylaxis would include heparin or a low dose of a low-weight heparin, like enoxaparin or Lovenox. And outpatients will be prescribed warfarin, also known as Coumadin.
So the PICO question that we're trying to answer here is, our population is hospitalized adults. The intervention is use of anticoagulants, specifically enoxaparin, and if it's always warranted in the adult population. We had a control group of no use of anticoagulants, specifically, again, enoxaparin, and the outcome we're looking for is, does it prevent thromboembolism? And our specific question is the broad use of anticoagulants indicated in hospitalized adults regardless of individual risk factors. We had 5 different articles that used 5 different methods. We used various databases, PubMed, SynHall, and Google Scholar. We searched for articles in English for the last 5 years between 2017 and 2022 in a hospital or acute care setting in the United States. The keywords were
I think he froze. The key words were
Go ahead, Haley.
Lovenox as prophylactics for adults. There he is. Go ahead, Greg.
what happened?
You froze. You're on keywords.
Oh man. Okay. Should we start over or is it still recording?
Just go, it's okay.
Just go to keywords.
Okay, the keywords were Lovenox as prophylactic for adults. Our research study designs were cross-sectional, retrospective cohort, quantitative experimental, and non-experimental retrospective.
So overall, based on all 5 articles, prophylaxis is not indicated for all hospitalized adults. The Height et al. Study concluded that despite the achievement of near universal in-hospital prophylaxis, hospitalization-related VTE attack rates did not change significantly, suggesting that such prophylaxis measures did fail. The Amen et al. Study further supported this with the conclusion that there's a need for improved utilization of pharmacological VTE prophylaxis in the acute care setting, due to the finding that 50% of all VTE events occurred after hospital discharge. The Mejia et al. Study provided insight on the current prescribing patterns for VTE prophylaxis and suggested that the measures taken to better the rates of VTE prophylaxis, such as dosing, guidance in relation to body weight, and if a renal issue is present. This was also supported by the Dibdal et al. Study that suggested decreasing the prophylactic enoxaparin dose in low body weight patients, especially in the elderly population. The last and strongest study was the Lay et al. Study, and it is a level 1 of evidence. It provided results that suggested a threshold that determined cost-benefit ratios to determine correct prophylaxis use.
Some inconsistent findings were among our studies were the Min et al. Study. The patients did not comply with the medicated prescribed regimen, and the documentation the hospitals provided was not to good standards. The Height et al. Study showed a VTE events did not change with prophylaxis, and the use of the compression devices on the lower extremities was not documented. The Mejia et al. And Dibdal study did not follow the patients after they left the hospital to see if the effects of the prophylaxis during hospitalizations were effective. And lastly, the Lee et al. Study used patients who are more acutely ill than a normal patient and also excluded those at high risk of bleeding from the study. Along with these inconsistent findings, our studies had a wide variety of variations. The first being the age groups that were studied. Some of them went all the way from age 17 to over 75 years old. And as you can assume, the incidence of DVTs and VTEs increased with age, so that could have resulted in the elderly studies having more incidence of the VTEs. The length of the studies studied were different in the fact that some only studied the patient while in the hospital and others followed them while they were out of the hospital, and that gives us more information to if they received the prophylaxis and got a VTE or not. The other problems and variations are that the SCDs and other factors were not documented. Also, early ambulation, range of motion were not evaluated throughout all the studies, which could have resulted in different outcomes and unknowns, such as if the anticoagulants or the interventions were causing the outcomes. Last but not least, the studies did not use the same anticoagulants or dosing. The different anticoagulants used in these studies were Lovenox, heparin, warfarin, and fondaparinux, which may work differently per patient and also have different side effects per drug used.
So in conclusion, we learned that VT can affect any hospitalized patient, and we've come to the conclusion that the current practice of prophylactic anticoagulants for every hospitalized patient is not the best practice. We know it's needed, but we come to know that factors need to be considered, such as the age, weight, comorbidities, life expectancy, bleeding risk, and renal functioning. So our goal is ultimately to continue doing prophylactic treatment, but to make them more patient-specific for considering these factors. That way we can improve the effectiveness and treatment of anticoagulant therapy. So our application for clinical practice, we need more studies to be done regarding VTE after discharge, especially since over 50% of patients will develop VTE after leaving the hospital setting. And as mentioned, the risk factors need to be considered, including renal impairment, age, weight, and comorbidities. And attached here is our reference page with all the research articles that were considered and additional supplemental writings that we used.
Thank you for listening.
Thank you.